Welcome back to class, everybody. We're going to take another little trip back into history today and kind of move over on the globe a little bit to look at another part of the world. And today we're going to be focusing on how the Bismarck model operates and was kind of initially created. So this is chapter 17. The title of the chapter is The Bismarck Model, Social Health Insurance. And similar to last chapter, I'm going to start with some background so you can kind of appreciate a little bit more kind of what prompted the institution of the Bismarck model. So in 1871, the Treaty of Frankfurt was signed, signaling the end of the Franco-Persian War and the political unification of German-speaking states and principalities across Central Europe. So this was kind of the introduction of what is now Germany. So this is the first modern Germany. The leader of this modern Germany was a man named Otto von Bismarck. And during the time that Bismarck kind of took over this modern Germany, there was support for socialism that was growing within this region. Bismarck viewed this as kind of a threat to his power. So to thwart the socialist political agenda, Bismarck's strategy was to win over the German workers who were employed in the growing industrial sector. So to do this, in 1881, Bismarck introduced a popular new policy designed to undermine support for the socialists, and this policy was universal sickness insurance. It's worth noting that the passage of Bismarck's insurance bill marked the foundation of the welfare state, and so out of this kind of attempt to kill socialism, ironically, we got the welfare state, and ironically, we got publicly provided insurance. So typically this is kind of counter to what we think of in terms of kind of how health care provided by the government fits in with socialist policies. Historically, public insurance was used to kind of stamp out socialism, and in today's political regime, specifically in America, we kind of see public insurance as going hand in hand with socialism growing. So that's kind of something interesting for you to mull over. After Bismarck introduced this universal sickness insurance for the working class in the industrial sector in the first Germany, his plan started to grow and it spread across the world, and other countries started to adopt it. Similar to Germany, Japanese politicians slowly adopted a universal insurance program to counter the popularity of left-wing political parties during the early 1900s. So when the Bismarck model was effectively adopted by Japan, it was done for the same reason that it was adopted in Germany. It was to kind of counter left-wing political agendas. So we had Germany with the Bismarck model, then Japan with the Bismarck model, and other East Asian countries kind of followed suit and started adopting this model during the late 1990s. In continental Europe, many countries also started to insure subsets of the working population. These countries included France, Switzerland, and the Netherlands. And then another country that also uses a healthcare framework that's similar to the Bismarck model is Israel. Israel adopted a managed competition model in 1995. So right now there's kind of a smattering of countries throughout the world that use this Bismarck model to kind of frame their healthcare system, and it's a really kind of unique assortment of countries. So it's Asian countries, Israel, and then some European countries as well. Okay, the countries that follow the Bismarck model don't all have identical healthcare systems, but they share three similar features. Feature number one is universal insurance. What this means is that nearly everyone is insured either through an employer-sponsored plan or public coverage. So there's universal insurance in the country, but it's not all necessarily coming from the government. Some of it is, some of it's also coming from employer-sponsored insurance. Feature number two is community rating. Okay, what this means is that insurance is financed via taxes rather than premiums, which are dependent on individuals' health. So by default, this means that healthy citizens effectively subsidize the care of sicker citizens. And we call this a community rating because the rating, or the amount you pay for insurance, which is your tax rate, is set by kind of the average cost across the community. It's not set on an individual basis based on an individual's level of health. Feature number 3 is regulated private healthcare provision. Okay, recall healthcare provision relates to who is providing healthcare, so these are doctors and hospitals. So regulated private healthcare provision means hospitals are privately run and physicians are not government employees. It's all private. But prices are set by the government in countries that use the Bismarck model. And when the government sets the prices, it does so in consultation with physicians and hospital managers. So this is really interesting when you kind of think about like how this would be kind of feasibly conducted. It varies slightly from country to country, but the idea is that for every single healthcare treatment or product or service that might be offered, the government has to decide what the price is going to be for everyone who utilizes that service or treatment in the country. And so there's like this enormous list of healthcare procedures that could be offered. The government has to go down that list and assign a price tag to every single one of those things. And it does so by bringing to the table physicians who kind of have kind of a better sense of what supply and demand for those services are and what the costs are, and hospital managers who again also kind of have their ear to the ground in terms of like what the appropriate costs are. And then people come to the table, and then on a somewhat regular basis, they just go through the list and assign a price for every single one of those things. And then across the country, anytime somebody uses a particular treatment or service, they or their insurance has to reimburse the private healthcare provider at the price that the government sets. So even though the hospitals and the physicians are independent of the government, they're all private, they have to abide by the government set prices. Just to kind of help you see how this stacks up against the Beveridge model. So similar to nationalized healthcare, which is what the Beveridge model is, in Bismarck countries, the healthcare of the sickest and poorest citizens is financed by the healthier, richer citizens, and it's done so via taxes. And also similar to the Beveridge model, in countries that use the Bismarck model, the government has the authority to set hospital and physician fee schedules. So this is a fee schedule it's basically a price for each thing. So in Beveridge countries where the government is just running the show, implicitly they're also kind of determining what they are going to get paid for the services they as the government provide, because they're setting the tax rates and they're providing the care. Dissimilar to nationalized health care, patients in Bismarck countries are free to choose when and where they want to seek medical care. So if you live in the UK, there is a particular hospital you have to go to. In Bismarck countries, there's a private market for healthcare. So if I, as a patient, see that one hospital and on the other side of the country has kind of chosen to provide more fancy elite medical services, I'm free to go there. So it's a private market. The prices are set, but if a hospital wants to offer a very elite service and then just price it at the level the government says, they're free to do so. If another hospital doesn't want to provide that free service, they don't have to. And then patients just go to whichever hospital they want to go to. Also, doctors are free to enter and exit the market and open a new clinic and just kind of do what they want in Bismarck countries. That is not the way it is in Beveridge countries. In countries that use the Beveridge model, again, it's the government deciding when and where to build hospitals and how many physicians to employ. In Bismarck countries, if I want to become a doctor, I don't have to get a job with the government. I just get my medical training out of the way and then join a clinic or find a hospital to work in. Okay, so now we're going to do kind of the reality check in terms of the pros and the cons of this particular healthcare system. So when we're thinking about countries that use the Bismarck model, they're kind of similar to countries that use the Beveridge model in that because of the universal insurance, there's a level of equity that's kind of maintained. So while it's great if the rich and the poor have equal access to healthcare, similar to the Beveridge model, and it's also great that the market is free to respond to economic forces, which is unique to the Bismarck model, there are still challenges that arise in social medicine. Challenge number one is prices for all medical transactions are set by the government. So we don't use this in most markets in the US, so it's kind of weird to think about. So let me just kind of be really explicit and tell you the pros and the cons of having medical prices set by the government. Okay, pros. First of all, this is potentially an effective way to control high prices. The idea is in the United States and our private, in some of our insurance markets, prices just get out of control because the hospitals can just charge whatever amount of money they want to for different services. And so we have enormously high prices for medical goods in the United States. In countries that use the Bismarck model, there's kind of a stop against that because the government is setting the price. So if the government is setting the price, they can, by blunt force, say the price of an x-ray is going to be $50, period. Like no one can charge more than that. So this potentially is an effective way to control high prices. Another pro is when setting the prices in Bismarck models, the government negotiates and reaches an agreement with providers or physicians. The negotiating parties, like what consists of a negotiating party, varies widely across countries. But the pro is that the government's ruling is influenced by the pulse of the market. The idea is that it's not just the government sitting in their own board room with closed doors kind of just determining prices. They invite people into the discussion, and particularly they invite in hospital managers and physicians. And these parties that they invite to negotiate in terms of setting the prices, they're the ones who are actually like in the thick of it in the market. So doctors kind of have a sense for like what is the demand for an x-ray, and then they can kind of bring that information to the table when the government is setting the prices for x-rays. The cons, and there's going to be one big con. The con is if the price of each activity or treatment is not set equal to its marginal cost of production, this may cause doctors to make medically questionable decisions when treating patients. Okay, this is a super important kind of limitation of government set prices. Okay, the idea is for every treatment that a physician might provide, there's going to be some marginal cost of that treatment. So it's kind of the additional cost that the physician has to incur because they're providing the treatment to a patient. So, for example, suppose the cost of providing a knee replacement surgery to a patient is $100. Well, what would be ideal is if the government, when they were setting their prices, they had the price for knee replacement set at $100. But what's inevitably going to be true is that since they're having to pick a price for every single itty-bitty thing that a hospital or a doctor might provide their patient, they're probably not always going to get the price point exactly aligned with the cost. Okay, now put yourselves in the shoes of a doctor who has a patient who comes in who needs knee replacement. Suppose the government one year they get it wrong in terms of the price they set for knee replacement, and they set the price lower than the cost. So the cost for the physician to provide a knee replacement is $100, and then the government erroneously or mistakenly sets the price at $80. Okay, if I'm a physician, I have this patient sitting in front of me, they need a knee replacement. I know it's going to cost me $100 to do it. If I do it, I'm going to get paid $80 because that's the price the government has set. In that situation, you're going to have some doctors who are going to be hesitant to actually do the surgery because if they do the surgery, they're going to lose money. And so this disalignment between the price that the government sets for the treatment and the cost of the treatment is going to cause doctors to make questionable decisions. And specifically in this case, if the price is set lower than the marginal cost, then doctors are going to underprovide the treatment because of this financial disincentive. But it's also going to work in reverse. So suppose the next year when the government is updating all of its prices, they get it wrong in the opposite direction and they set the price for knee replacements at $150. Well, if the cost of a knee replacement from the perspective of the doctor is $100, then the patient comes into the doctor's office, the doctor looks at their knee, they say, you know what, it looks like you might need knee replacement. If the doctor knows that the cost for him to provide that knee replacement is $100, and if he does it, he'll get paid $150 because that's the price. Well, then anytime the patient might possibly need a knee replacement, of course the doctor is going to have an incentive to just go ahead and do it, because the doctor is going to make money off of providing that treatment that is priced above the marginal cost. So in that case, the decision the doctor makes is going to be influenced by profitability, and so they're going to kind of over-provide treatments. And again, this is problematic because we don't want the doctor's decision of whether to provide a treatment to be influenced by the amount of money they make. We just want it to be influenced by what's best for the patient. Okay, this actually is a problem that materializes in the real world. So in Japan, one of the countries that uses the Bismarck model, the government sets the prices. And for reasons that I won't get into, every year the government overprices prescription medicine. So what that means is the government says the price tag for this prescription is going to be, for example, $1,000, whereas the cost for the physicians to provide the medicine is going to be less than that amount. Okay, what this has resulted in Japan is doctors prescribing tons and tons of medicine for Japanese people, because they know as soon as they write a script, like, they're going to make money off of it because the price is set too high. And so in Japan, if you look at kind of the percent of healthcare spending that goes towards prescriptions, it is way out of whack. Like, they spend so much money on prescriptions in Japan relative to the US, and that's in part an artifact of the fact that writing prescriptions is profitable in Japan because the government price is too high. Another interesting kind of story, the textbook mentions this, and I'll just mention it in the lecture. The U.S. Medicare system, so this is like a component of U.S. healthcare that actually, it's government-provided insurance to a subset of the population. It's to people who are 65 and above. The Medicare program in the U.S., it also has prices that are set by the government. So for older folks who have a Medicare card, when they go to the doctor and they get their services, the government has particular prices or fees that are attached to each service, and so the government, DC, will just send the doctor the Medicare price. So years ago, the U.S. government, when they were setting the prices for Medicare patients, when they came to cochlear implants, they set the price too low. So physicians in the United States had a given cost to provide their patients with cochlear implants. This is an implant that just helps a person hear. And the government set the price tag that they would reimburse the physicians for cochlear implants a lot lower than the marginal cost. And so what happened in the United States was there are a lot of deaf people who went to the doctor. The doctor knew that a cochlear implant would restore their hearing, but the doctor also knew that if this patient had Medicare, then the U.S. government would not pay them the full cost of giving them the implant. And so a lot of people didn't get cochlear implants in the United States just because there's this disalignment between the price that Medicare would pay for cochlear implants versus the physician's actual cost of providing it. And so a lot of deaf people just did not get the appropriate care for a while because the price was out of line with the marginal cost. Okay, so that's a super long description of challenge number 1. So challenge number 2. Some Bismarck countries are adopting gatekeeping. Recall, gatekeeping is just this process whereby if a patient wants to get to a specialist, they first have to go to a primary care physician. The primary care physician makes a referral, opens the gate to the next doctor makes a referral, opens the gate to the next doctor, and then eventually you work your way up the chain and you get to the specialist. Traditionally, Bismarck countries allowed patients to seek care from whichever provider or specialist they wanted to. And so kind of the purest form of a Bismarck model is we want patients, we want equitable care. So we want patients to kind of go to the doctor they want to go to regardless of anything. But now they've kind of deviated from that purist stance, and some countries that use the Bismarck model are adopting gatekeeping. Okay, so recently, France and Germany have introduced soft gatekeepers. Soft gatekeepers are physicians who manage the referral of patients to specialists in other hospitals. But it's soft because patients can avoid gatekeepers and go straight to specialists if they pay a small fee. Okay, What this means is that the gates are no longer relevant if you are rich and you can pay the fee, and you can just go straight to the specialist and bypass having to like first go to your primary care physician. And so the reason this gets labeled as a challenge is because, again, it deviates from the purist stance that like we're going to have equitable care. If you have soft gatekeeping, then this advantages the rich people over the poor people. Challenge number 3 is some Bismarck countries are adopting health technology assessment. Okay, recall health technology assessment is this idea of having kind of cost effectiveness analysis that says this is the price tag for each good in terms of how much you'd have to spend to get one quality adjusted life year. Traditionally, Bismarck countries left the adoption of health technologies unregulated, while Beveridge countries had centralized control of health technology adoption. So in Bismarck countries, if the market was characterized by sufficient demand for a treatment or a product, then because Bismarck countries had private hospitals, those private hospitals were free to just adopt whatever medical technology they wanted. In other words, if there was like this really expensive machine that could just save a few people's lives, well, in Bismarck countries, we have a private hospital system. So the hospitals could just buy that machine if they wanted to, and they could offer it to their patients. Given they'd have to like have the price that the government set, but the hospitals could just invest in whatever equipment they wanted to, charge patients the set price for it. But there was no kind of limit in terms of how fancy of equipment the hospital can invest in. But recently, some countries in the Bismarck world have established agencies to undertake health technology assessment. Although these agencies don't necessarily restrict coverage for inefficient technologies. So the idea is similar to NICE in the UK. Some of the countries that use the Bismarck model have kind of introduced these agencies, which go and look at different medical treatments, and they say, here's kind of the stack up in terms of cost effectiveness. So for this particular treatment, it buys you one quality adjusted life year at a price of $50,000 or $60,000. And then they subtly kind of encourage the private hospitals to not invest in the machines that are super expensive. So these aren't super popular agencies because even though they don't necessarily have any bite in terms of telling hospitals that they can't invest in expensive machines, they're kind of seen as, this isn't exactly the correct word, but they're kind of seen as like bully agencies because they kind of make these recommendations to kind of push hospitals into behaving in a particular way that the government might like. And that effectively is an encouragement for hospitals not to invest in machines that are super expensive. So that's another challenge that Bismarck countries are currently facing. Okay, that's all that I have for the Bismarck model. If you have any questions about this in the next 10 minutes, let me know. And then after this, we're going to do the exercise for the day. And so I will see you then. Today's exercise is going to involve another reading assignment. So I pulled an article today from the Washington Post. This article, again, it's a little bit outdated, but it covers a lot of the information that we talked about in class, so it's still relevant. The name of the article is Japan's Healthcare System Has Many Advantages, but May Not Be Sustainable. So for the exercise, what I would like you to do is I want you to, first of all, just read the article. And then what I want you to do is I want you to pick one of the prompts that's on the screen and then write 2 to 3 paragraphs on the prompt using the information from the article. So actually make sure you're pondering this for a little bit so you have enough content to fill up 2 to 3 paragraphs. The possible prompts that you can write on are, first of all, moral hazard in Japan. So recall what moral hazard is. Moral hazard is if you give somebody insurance, either that causes them to change their behavior such that they need more health care, or it causes them to change their behavior such that they overutilize health care. The article talks in length about this kind of happening in Japan, so that's one prompt you might pick. The second prompt is you could talk about just kind of how gatekeeping looks in Japan. The article describes how there's not a lot of gatekeeping in the Japanese healthcare system, and this has created some problems, so you can discuss that for 2 to 3 paragraphs about kind of what gatekeeping looks like in Japan, or specifically what it doesn't look like in Japan, and kind of the problems that has led to. Another possible prompt is you could talk about the heavily regulated healthcare provision in Japan. Recall that one of the features of the Bismarck model is heavily regulated private healthcare provision, and specifically the heavy regulation often comes in the form of government set prices. So the article also kind of talks about how the government set prices in Japan have impacted things. Another prompt is to think about the health policy trilemma, where a policymaker wants health, wealth, and equity, but they can't get all three maximized at the same time. So you could talk about which of those 3 things, I'm calling them bubbles, Japan is prioritized at the expense of others. You can also talk about universal insurance in Japan. The article talks about the fact that everybody is insured and kind of how they're insured. And then the last possible prompt you can choose from is you could talk about community rating in Japan. So recall from today's lecture, community rating is basically that people don't pay for their insurance based on their own individual health. It's kind of like you're rated or you're charged kind of based on the overall health of the community, and often this is done through taxes or through kind of employers providing insurance and then kind of basing things based on employee pools instead of individuals. So again, just pick one of these things, and then after you read the article, just kind of discuss one of these prompts for 2 to 3 paragraphs. That will be it for the day, and then I'll see you back for the next class.